after 20 years as a patient safety expert and a culture expert, the stories and the things I saw, I was hopeless. Nurses Transforming Healthcare, though, is what inspired me and gave me energy again, because I could see a future for healthcare. I could see it working. So the goal of Nurses Transforming Healthcare, founded by John, myself, Leanne Meyer, and Kim Evans, it started about 3 years ago, is to transform healthcare from a business that profits on disease to a service that thrives on wellness. We're not just a nonprofit. What we are is a social movement, because we want to change healthcare from a business that has a commodity, to a service. And underlying that is research. Donna Bedian said, structure dictates process, which dictates outcomes. And LinkedIn is filled with, the outcomes of burnout and suicide and demoralization and poor care and providers being exhausted and patients not getting the care they deserve. But I think people don't understand is there's a lot of good people trying to change the processes. But what we believe is you got to change the structure. Our healthcare system is perfectly designed to produce more sick people every year. It's actually working well. It's working just how it was designed. So in order to impact change, what we realized is we have to create a new structure. And that was the adapted public utility model. That's the idea that we put forth as a brand new structure. We're having a Flip Your Zip campaign. We're focused on taking one zip code in America. And what if we could take, Prescribe Hope, the Ames model from the University of Washington, the Costa Rica model, Nuka Health in Alaska, and all the wonderful things, mobile clinics, primary care, the essence of which this whole model is what Todd said, the relationship that the provider has with their patients. What if we could reclaim that back again and put that all into one zip code? When you look at how you're going to build a structure, John looks at, the 7 goals. Healthcare should be local. Complexity science says that no person, no matter how wise or powerful, can control outcomes from the top. We need to stop and make a local model where the focus is the relationship with the primary care giver. And we don't just address the social determinants of health. We actually have the resources and give this zip code the autonomy to decide, what do you need in your zip code?
I was really intrigued with what's wrong with healthcare and how do we fix this. I'd already been an ER nurse for 5 years. I heard all the stories. I continued for another 5 years into my doctorate as a practicing ER nurse because it was like this huge research laboratory of people coming in, telling me what their problems were and why they had to see an ER at 8 o'clock at night instead of going to see primaries or specialists. So what I soon realized was that nobody had really put together a cohesive set of goals of what a healthcare system was supposed to do. So I set out kind of attacking this problem, I thought, as a philosopher. And I put everything on the table, including tearing down the whole system and starting over again. So I developed 7 goals that I thought a healthcare system had to have. So I got these 7 goals together and I decided, the systems were the problem. It wasn't the individual process. So I came back and I put every system design I could see around the world. It was a coherent system design on the table. And I went through them one by one, see which ones met all 7 goals. It turned out none of them did. And the good news is our system design, if you want to call it a system, didn't meet any of the 7 goals. So then I had to kind of rethink things. And I thought, philosophically, the problem we have in our country is we've never really decided or had the discussion of whether healthcare is a right or privilege. We tend to have 2 camps and, one in each pole, but that's about it. And we've never really had an agreement. And of course, if you think of healthcare as a right, then you're pretty much looking at some kind of federal financing system, single payer, something like that, which is going to involve tax money. If you think of healthcare as a privilege, well, then you have to be willing to step over the dead bodies of other Americans. So I thought, what's in the middle? We had to have had a problem in this country before where we weren't willing to call something a right, but it was too important just to be a commodity. So I went back and studied U.S. history, and I found the FDR solution to the electrical problem in the early 1920s. Electricity at that time had a lot of the same problems healthcare has now, distribution of resources, a lot of LLCs over these corporations that controlled electrical production, and then a lot of neglect for zones, communities, rural communities, inner city communities that couldn't really afford the rates that they just made up and charged. Sound like healthcare? Yeah. So I looked at the public utility solution that FDR had come up with, and I studied the natural monopoly theory back into England because that's where it came from. So I said, all right, well, and I brought the public utility model forward and put it on the table. And I found out if I changed 2 of the things, if I changed the administrative structure and I give it a sustainable financing model, that this system design takes healthcare, and not just healthcare, innovative healthcare, right down to the street level in every community. It also opens up the door to things like Kathleen was talking about, addressing the social and economic determinants of health. Well, at least those a healthcare system can design. And since these systems would be integrated with each other, but they're no longer competitive. So they can help each other, for example, in disasters. If there's tornadoes 20 miles away, we can mobilize regional healthcare resources in to help there. The regional systems are governed by a council of interdisciplinary providers. And this was the big administrative change I thought had to happen. Because as it stands now, the system goals and the provider goals are asynchronous. And we have to restore that system design to the goals of, medicine and nursing and the other healthcare professionals, and most of whom have codes of ethics like we do. And the other advantage of this was that it also included academia, public health, EMS at these tables that decide key issues, for example, distribution of resources, community needs, and then what we can work together to come in to deliver those services to the communities. If you go down the goals, it kind of outlines the evolution of this model.
What we learned, and this is what I want to throw out to you and ask for your help with, is that after we look at the money spent and after for the nurse practitioner, and we look at all the outcomes, all the Z codes that have been captured, all the Z codes that have been resolved, all the money that has been captured for these people, instead of the church just handing out, they had a ton of resources that they were entitled to that as we know in the country, the resources aren't getting to the right people. So that did that as well. But they're on the Excel spreadsheet. When you look at it, there is no column. If you're going to change healthcare from a business to a service, you need more columns on your spreadsheet. Where's the column for the connection and the relationship that the patient has with their primary care provider? Where's the column for genuine caring that motivates another person because you care about them to care about themselves? Where's the column for increased connection? Because we know that there's social, disconnection, and only 16% of Americans feel connected to their communities. So as you create a new movement, or as we switch this to a service, we need different measures. What do you want to measure? The quality of life index is a good one that is being used. But do we ask that question? Are you happy? Do you actually perceive that your caregiver cares about you? Do you feel cared for? These are important questions when you create a model that is based on service.
I want to clarify one thing. This is not a competition between nursing and medicine. We need everybody working as partners together to address these needs in a very complex geography. So we have an advantage other countries do not have to get out and, again, work in partnership with medicine, with pharmacy, with nutritionists, with physical therapists to really bring health into the communities. And then understanding that community health is not just how many diseases are there and how many hospitalizations we can reduce. A healthy community has a sense of optimism, of progress, of being engaged in the community at large. And while healthcare can't solve anything, everything by itself, having some kind of resource in a community allows you to bring in other state resources, for example, that can augment the health of the communities. Go back to the fact that we have no idea how much healthcare actually costs in this country. And there's multiple reasons for that, but if you've ever read, for example, Uwe Reinhardt's work, and you look at how pricing was developed in healthcare, they basically just made all this stuff up. So I'm thinking that, when I looked at my model and we did the economic analysis, we're showing a 42% reduction in healthcare costs in this country, which is a pretty big chunk of money. So one of the goals in this utility model I'm talking about is cost efficiency. And so part of that is these regional systems working under a budget, and then they can decide the innovative strategies that they need to reach particularly small communities, which is a very difficult challenge when they're 60, 80 miles away from, metro areas. But I think the solution to that really is nursing innovation. So Kathleen said a lot of people don't understand nursing. We've got over 140-year history of finding people in this country that need help and helping them, whether it was tenement buildings or rural gullies in West Virginia or small desert communities in Arizona. So this kind of innovative delivery is inherent in nursing. And when you add in the fact that the reason I put nursing as the chair of the regional systems was that we have an ethical obligation and understand that healthcare is not just this patient in this bed, but it's also a broader picture of communities and states and national health. And again, we work as partners to do that. So there's going to have to be, other economists that come in and say, okay, so this is the budget. How do we arrange that with some kind of progressive level of payment? But whatever it'll be a lot less than everybody's paying now.
And none of us can do this alone. We're so excited to collaborate. That gives me more hope than anything. We need each and every person on this call and your wisdom and your expertise and your input, to make it happen. You believing that everyone has a right to be well. If we believe that and hold that up, and then as Todd was saying, the sacred, what a great word, Todd. The sacred relationship, reclaiming that sacred relationship between the physician and the patient, the nurse and the patient, reclaiming that is really the essence of any new system, because that relationship has been lost.
Not only does everybody have the right to be well, we cannot be a well society if we do not have the vast majority of us being well, because those people who are not being treated will be sick. They will spread whatever sickness that they have. So the idea that we don't want to give something like this away, the idea is we need it for everyone to be healthy. We have to have, people taking care of themselves and being taken care of in ways that move us forward to a healthier country. Right now, we're sitting ducks.